Eating disorder. Case study for eating disorders from DSM-4 casebook in Kaplan and Sadok, page 723. When Peggy was first evaluated for admission in the eating disorder program, she was a 20-year-old woman who had difficulty supporting her 5'3" body with a weight of only 67 pounds. She began to lose weight 4 years earlier, initially dieting to lose an unwanted 6 pounds. Encouraged by compliments on her new body, she proceeded to lose 8 more pounds. Over the next 2 years, she continued to lose weight, increase her physical activity until her weight reached a low of 64 pounds and stopped menstruating. She was admitted to a medical unit, treated for peptic ulcer disease, and discharged only to be admitted 3 months later to the psychiatric unit of a general hospital. During that 8-week hospitalization, she went from 84 pounds to 100 pounds. She did well until she went off to college, where with increased academic and social demands, she again to diet until she weighed only 67 pounds. Her eating habits were ritualized. She cut food into very small pieces, moved them around the plate, and ate very slowly. She was troubled by the changes in her body and became increasingly anxious as her figure developed. She was forced to drop out of school and to accept another hospitalization. Peggy was motivated to comply with treatment, but her fears of gaining weight and becoming obese affected her progress. She was expected to gain a minimum of 2 pounds every week, and she was restricted to bed rest if she failed to gain sufficient weight. In psychotherapy, Peggy was gradually guided to discuss her feelings and actually look at herself in the mirror. She was initially instructed to look at one part of her body for a minimum of 10 seconds, and the time was progressively increased until she could look at her body without any anxiety. Her menses returned at a weight of 93 pounds. After 7 months of individual and family treatment, she was discharged at a weight of 100 pounds. Peggy returned to college, worked part-time, and lived with her parents. Clinical descriptions: anorexia nervosa has 3 characteristics: restriction of behaviors to promote a healthy body weight, an intense fear of gaining weight and being fat, and a distorted body image. Anorexia usually begins in the early teen years and is more common in women than men. Bodily changes that can occur after severe weight loss can be serious and life-threatening. About 70% of women with anorexia eventually recover, but it can take many years. Anorexia nervosa, a disorder in which a person refuses to maintain normal weight, has an intense fear of becoming obese, and feels fat even when emaciated. Bulimia nervosa involves both binging and compensatory behavior. Binging often involves sweet foods and is more likely to occur when someone is alone, after a negative social encounter, and in the morning or afternoon. One striking difference between anorexia and bulimia is weight loss. People with anorexia nervosa lose a tremendous amount of weight, whereas people with bulimia nervosa bulimia typically begins in late adolescence and is more common in women than men. Depression often occurs with bulimia, and each condition appears to be a risk factor for the other. Dangerous changes to the body can also occur as a result of bulimia, such as menstrual problems, stirring in the stomach and throat, and swelling of the salivary glands. Bulimia nervosa, a disorder characterized by episodic, uncontrollable eating binges, followed by purging either by vomiting or by taking laxatives. Binge eating disorder is characterized by several binges, and most but not all people who suffer from it are obese, defined as having a body mass index or BMI greater than 30. Not all obese people meet criteria for binge eating disorder. Only those who have binge episodes and report feeling a loss of control over their eating qualify. Binge eating disorder is more common than anorexia and bulimia, and is more common in women than men. Though the gender difference is not as great as it is in anorexia and bulimia, changes to the body occur with binge eating disorder, and not all of these are due to the co-occurrence of obesity. About 60% of people with binge eating disorder recover, but takes even longer than recovery for anorexia or bulimia. Binge eating disorder, included as a disorder in DSM-5, includes recurrent episodes of unrestrained eating. Body mass index (BMI), measure of body fat calculated by dividing weight in kilograms by height and meters squared, considered a more valid estimate of body fat than many others. Obese, currently defined as exhibiting a body mass index of greater than 30. Etiology. Genetic factors appear to play a role in both anorexia and bulimia. Both disorders tend to run in families, and twin studies support the role of genetics in the actual disorders and particular characteristics of the disorder. There's such as body dissatisfaction, preoccupation with thinness, and binge eating. The hypothalamus does not appear to be directly involved in eating disorders, and low levels of endogenous opioids are seen concurrently with bulimia. But not before the onset of the disorder, these changes in food intake could affect the opioid system instead of changes in the opioid system affecting food intake. Research findings on the role of serotonin in anorexia are mixed. Serotonin may play a role in bulimia, with studies finding a decrease in serotonin metabolites and smaller responses to serotonin agonist. Newer research suggests dopamine may play a role in restrained eating, a characteristic that is found in people with eating disorders. The neurobiological factors do not do a particular good job of accounting for some key features of anorexia and bulimia, in particular the intense fear of becoming fat. Cognitive behavioral theories focus on body dissatisfaction, preoccupation with thinness, and attention and memory. The restraint skill measures concern about dieting and overeating, and high scores are linked to binge eating among people without eating disorders. The eating pattern of people with bulimia and binge eating disorder is similar to, but more extreme than, the behavior highlighted in the studies of restrained eaters. Studies have found that concerns about body shape and weight predicted restrained eating, which in turn predicted an increase in binge eating. People with eating disorders pay greater attention to food and body image related things, and they tend to remember these better as well, suggesting that their attention and memory may be biased toward food and body image. Social-cultural factors, including society's preoccupation with thinness, may play a role in eating disorders. This preoccupation is linked to dieting efforts, and dieting precedes the development of eating disorders among many people. In addition, the preoccupation with thinness, as well as media portrayals of teen models, predicts an increase in body dissatisfaction, which also precedes the development of eating disorders. Stigma associated with being overweight also contributes. Women are more likely to have eating disorders than men, and the ways in which women's bodies are objectified may lead some women to see their bodies as others do, self-objectify, which in turn may increase body dissatisfaction and eating pathology. Anorexia appears to occur in many cultures. Bulimia appears to be more common in industrialized and westernized societies. Eating disorders are slightly more common among white women than women of color, with the difference between most pronounced in college student samples. Eating disorders used to be more common among women of higher socioeconomic status, but this is less true today. Research on personality characteristics finds that perfectionism may play a role. Other personality characteristics that predicted disordered eating across 3 years include body dissatisfaction, the extent to which people can distinguish different biological states of their bodies, and of a propensity to experience negative emotions. Troubled family relationships are fairly common among people with eating disorders, but this could be a result of the eating disorder, not necessarily a cause of it. High rates of sexual and physical abuse are found among people with eating disorders, but these are not race factors specific to the development of eating disorders. Treatment. Antidepressant medications have shown some benefit in the treatment of bulimia, but not anorexia. However, people with bulimia are more likely to discontinue therapy. Psychological treatment of anorexia must first focus on weight gain. Family therapy is common for anorexia, but studies are needed to demonstrate whether this is effective. The most effective psychological treatment for bulimia is cognitive behavior therapy. CBT involves changing a patient's beliefs and thinking about thinness, being overweight, dieting and restriction of food, with the overall goal being to establish normal eating patterns. CBT alone is more effective than medication treatment. Through antidepressants can help lessen comorbid depression. CBT is also effective for binge eating disorder. Prevention programs show promise, particularly those programs that include girls aged 15 or older, involve more than one session, and are interactive rather than didactic. In other words, lecture format. Outcomes appear promising up to 3 years after the prevention programs are instituted. Additional notes in eating disorders: obesity. 1/3 of U.S. adults, 17% of children are obese. 2012 figures: 5 to 7% of all health care costs are due to obesity. People today live in a toxic environment of high fat, high calorie, and expensive food, and advertisers who promote the consumption of large quantities of this food. In addition, there has been a significant reduction over the past several decades in the amount of physical activity people engage in. K. Brownell, 2004, more than 60% of Americans get less than 30 minutes of physical exercise per day, and 25% get no exercise at all. 2008 study. In addition, there is increasing evidence that ultra-processed foods sold by fast food restaurants can create addictions similar to those created by drugs of abuse. Food companies have manipulated the fat, sugar, and salt, food additives, flavor enhancers, and caffeine in ways that increase flavor and result in quicker absorption of ingredients such as sugar into the bloodstream, increasing the food's addictive properties. 2011 study. Biological factors in feeding and eating disorders. Genes appear to carry a general risk for eating disorders rather than a specific risk for one type of eating disorder. A genetic risk for eating disorders appears to interact with the biological changes in puberty that contribute to the onset of eating disorders in girls but not in boys. In other words, in girls, changes in hormones at puberty may activate a genetic risk for eating disorders. Psychological factors: dichotomous thinking, judging things such as food as either all good or bad. Sociocultural factors, social pressures and cultural norms. Certain groups within a culture, such as athletes, may have standards for appearance that put them in at great risk for developing an eating disorder. Sports that emphasize weight are especially likely to encourage eating disorders. Aesthetic sports, figure skating, gymnastics, 35% have an eating disorder. Weight-dependent sports, judo, wrestling, 29%. Endurance sports, given example, cycling, running, swimming, 20%. Technical sports, given example, golf, high jumping, 14%. Ball game sports, given example, volleyball or soccer, 12%. Since the mid-20th century, models in fashion magazines, winners of beauty pageants, given example, Miss Universe, and even Barbie dolls, icons of beauty for women, have all been getting thinner. 1992 study. Body dissatisfaction fed by pressures to be thin is one of the strongest predictions of risk for the development of eating disorders in young women. Treatment for eating disorders: cognitive behavioral therapies are the most researched treatment for anorexia nervosa. The client's over-evaluation of thinness is challenged, and rewards are made contingent on the person's gaining weight. If the patient is hospitalized, certain privileges in the hospital are used as rewards, such as going outside the hospital for shopping trips or receiving family visits. The client may also be taught relaxation techniques as she becomes extremely anxious about ingesting food. In family therapy, the person with anorexia and her family are treated as a unit. The best studied type of family therapy is the Maudsley model. Parents are coached to take control of the child's eating and weight. As the therapy progresses, the child's autonomy is linked explicitly to the resolution of the eating disorder. Cognitive behavioral therapies have received the most empirical support for treating bulimia nervosa. This therapy is based on the view that extreme concerns about shape and weight are the central features of the disorder. The therapist teaches the client to monitor the cognitions that accompany her eating, particularly the binging and purging episodes. Then the therapist helps the client confront these cognitions, develop more adaptive attitudes toward weight and body shape. The behavioral components of this therapy involves introducing forbidden foods such as bread back into the client's diet and helping the client confront her irrational thoughts about these foods. Given example, if have just one donut, I'll end up binging. Similarly, The client is taught to eat 3 healthy meals a day and to challenge the thoughts she has about these meals and about the possibility of gaining weight. Cognitive behavioral therapy has been found to be more effective than drug therapies in producing complete cessation of binge eating and purging, and in preventing relapses over the long term. Expanded cognitive behavioral therapies that also address emotional regulation difficulties are especially effective in people with a combination of eating disorders and depression. Interpersonal therapy. The client and therapist discuss interpersonal problems related to the client's eating disorder, and the therapist works actively with the client to develop strategies to solve these problems. Supportive expressive psychodynamic therapy. One therapist encourages the client to talk about problems related to the eating disorder, especially interpersonal problems, but in a highly indirect manner. Behavioral therapy, the client is taught how to monitor her food intake, is reinforced for reintroducing avoided foods into her diet, and is taught coping techniques for avoiding binging. Comparing cognitive behavioral therapy with interpersonal therapy, supportive expressive therapy, and behavioral therapy, it was determined that cognitive behavioral therapy and interpersonal therapy showed the greatest and most enduring improvements. And cognitive behavioral therapy is significantly more effective than interpersonal therapy in treating bulimia and works more quickly. Cognitive behavioral therapy has also been shown to be more effective in treating binge eating disorder than other psychotherapies or antidepressant medications. Cognitive behavioral therapy reduces binges as well as over-concern with weight, shape, and eating in people with binge eating disorder. While the antidepressants like SSRIs, give an example Prozac, appear to reduce binge eating and purging behaviors, they often fail to restore the individual to normal eating habits. Adding cognitive behavioral therapy to antidepressant treatment increases recovery rates.